Fractional flow reserve, FFR, has several clinical indications, including assessing functional severity of intermediate coronary lesions, distinguishing focal coronary artery disease from diffuse coronary artery disease, identifying culprit lesions in patients with multivessel coronary artery disease, and assessing for optimal stent implantation. The indications and potential risks and benefits of the procedure are discussed with the patient and informed consent is obtained. A focused physical exam including auscultation of the heart and lungs, visual assessment of the oropharynx, and palpation of the pulses is performed to assess the patient's risk for receiving conscious sedation. The patient is placed supine on the catheterization table with both groins exposed. Hair is removed with a razor, and the areas are scrubbed and cleaned with a sterile soap solution. Also seen here is the equipment table, which holds all of the equipment necessary to perform diagnostic coronary angiography, including catheters, needles, wires, etc. Following cleaning, the patient is draped with a sterile drape, which has two circular holes in the drape to provide exposure of the bilateral femoral areas. In this example, the tubing for the contrast injection system also serves as the tubing for invasive hemodynamic monitoring. This setup is similar to that of a standard injection manifold. The contrast injection system is prepared by attaching all tubes to the power injector and flushing the system with both heparinized saline and IV contrast. The first step in obtaining femoral artery vascular access is to define general landmarks such as the location of the iliac spine, pubic tubercle, and femoral artery pulse through palpation. The objective is to puncture the artery on the anterior surface, below the level of the inguinal ligament, which runs between the iliac spine and pubic tubercle. It is also customary to mark the proposed access point with a hemostat and image the groin area using fluoroscopy. The goal is to have the arterial puncture entry site to be located in the lower to mid-third of the femoral head. 1% lidocaine is administered at the skin and into the soft tissue around the access site for local anesthesia. A micropuncture technique for vascular access is demonstrated in this video. The artery is palpated with the left fingers, and the artery is stabilized between the fingers. The micropuncture needle is advanced at the predetermined skin puncture site and advanced until the artery is entered and arterial blood is visualized within the needle hub. The needle is stabilized and the microwire is advanced through the needle and into the vessel where it is visualized under fluoroscopy to advance into the distal aorta, thereby verifying that the wire is not entering any accessory vessels branching off of the femoral or iliac arteries. The micropuncture needle is removed over the wire and a microcatheter is advanced through the skin and into the vessel. The dilator and microwire are removed and a standard J-tipped wire is advanced through the microcatheter into the descending aorta. The microcatheter is removed over the J-tipped wire and the standard vascular sheath, either 4, 5, or 6 French in size, is advanced. The sheath dilator and J-tipped wire are removed, and the sheath is flushed with heparinized saline. In this example, a 6 French JL4 guiding catheter will be used to cannulate the left coronary artery in preparation for FFR. Various anatomic factors such as a lesion location and tortuosity play critical roles in the choice of guide catheter curves. Also seen here is a copilot hemostatic adapter, through which interventional equipment such as wires and balloon catheters are advanced into the coronary artery. The hemostatic adapter is attached to the proximal end of the guide catheter and is then connected to the hemodynamic monitoring system via either the power injector, used in this example, or a standard manifold hand injector. Coronary catheters are always advanced over a guide wire, typically a J-tipped guide wire, with the tip of the guide wire as the leading edge in advancement. The catheter and wire combination is advanced to the aortic root, where the guide wire is removed and the catheter is attached to the hemodynamic and injection tubing. An automatic contrast power injector with an integrated hemodynamic monitoring system is used in this video, although a standard catheterization manifold may also be used if a power contrast injector is not available. The catheter and injection tubing are aspirated, cleared of any air bubbles. The hemostatic adapter is opened to allow bleedback to further verify the absence of air bubbles or plaque within the guiding catheter, and the entire system is flushed with heparinized saline, following which the hemodynamic system is zeroed. Once zeroed, the transducer is opened and central aortic pressure is transduced from the patient. At this time, the patient is administered systemic heparin IV to achieve an activated clotting time, ACT, greater than 250 seconds, which will be maintained throughout the IVUS procedure. After pressure is recorded, the tubing and catheter are filled with contrast, and the left coronary artery is selectively cannulated by both advancement or retraction and clockwise or counterclockwise torque of the catheter. Typically, the fluoroscopy detector is positioned in the LAO20 angulation for engagement of the coronary ostia. Once the left coronary artery is cannulated, an observation of the hemodynamic pressure tracing does not demonstrate pressure damping, a small test injection of contrast may be administered to verify successful cannulation and coaxial angulation of the catheter tip to the vessel. At this point in the procedure, coronary angiography begins, the details of which are highlighted in another video tutorial. In this example, an intermediate stenosis in the ostial proximal left anterior descending artery will be further evaluated by fractional flow reserve. The FFR wire is prepackaged in a plastic hoop. On the distal end is a floppy wire tip where the pressure manometer is integrated into the wire, approximately 2 to 3 centimeters from the tip of the wire. At the proximal end of the wire are a wire torque device and an electrical interface plug, which attaches to the FFR console where hemodynamic tracings are monitored. The wire is flushed with heparinized saline while it is kept in the plastic hoop. The proximal electrical interface is then plugged into the FFR console. The FFR wire hemodynamic tracing, green, and cath lab monitoring hemodynamic tracing, red, are both zeroed. The wire is then calibrated. The distal tip of the wire is then shaped in order to allow for directionality during wire advancement in the coronary artery. At this time, the FFR wire is ready to be introduced into the coronary artery of interest. The FFR wire is advanced through the guide catheter so that the pressure manometer on the wire is positioned proximal to the lesion of interest in a relatively normal-appearing segment of vessel. In this case, the pressure manometer is positioned in the proximal left main coronary artery. The wire introducer is removed. The catheter is flushed with heparinized saline to remove the pressure damping effect of IV contrast, and the FFR wire is equalized to the systemic aortic pressure, and the baseline FFR, designed as PD-PA in yellow on the video, is established at 1.0. Following successful equalization, the FFR wire is advanced so that the pressure manometer is distal to the lesion of interest. After the wire is advanced, the wire introducer is removed and the catheter is flushed with heparinized saline, and a baseline FFR measurement is noted. In this case, the baseline FFR value is 0.94 to 0.95. An infusion of IV adenosine is then administered per protocol for 2 minutes to induce maximal hyperemia in the coronary artery. During adenosine infusion, the patient may experience nausea, flushing, and/or chest discomfort. These symptoms are secondary to adenosine infusion and quickly resolve upon termination of the infused drug. Alternatively, intracoronary injection of adenosine may be administered in escalating doses. However, it is felt that continuous IV infusion of adenosine is more reliable as it provides a more consistent pharmacologic and physiologic steady state. During adenosine infusion, the hemodynamic tracings and FFR can be monitored in a live fashion. After approximately 2 minutes of IV adenosine infusion, the lowest recorded FFR is recorded, in this case approximately 0.82. A functionally significant lesion is one with an FFR of less than 0.80. The FFR wire is then slowly pulled back proximal to the lesion of interest in order. This maneuver is performed to assess for the presence of tandem lesions, which may impact overall FFR of the distal lesions, and/or to verify the fidelity of the system, as the FFR should near normalize upon pullback to the normal reference vessel. At this point in the procedure, the adenosine infusion is discontinued and the FFR wire is removed. Repeat coronary angiography may be performed at this time to verify that the instrumented coronary artery has not changed from baseline. Based on scientific data, a functionally significant stenosis is one that demonstrates an FFR less than 0.80. In this case, given the FFR of 0.82, the lesion is determined to be functionally non-significant. After the study is complete, the vascular sheath is routinely sutured in place until the activated clotting time returns to baseline. Once the activated clotting time returns to baseline, the sheath is removed. During sheath removal, it is important to monitor the patient's vital signs closely, as vasovagal reactions manifesting as hypotension and/or bradycardia may occur. If hypotension is observed during sheath removal, this can typically be remedied by small boluses of IV fluid. If bradycardia is observed during sheath removal, this can typically be remedied by small doses of IV atropine. Once the patient is felt safe for transfer, he or she is attached to a hemodynamic monitor and transported to the appropriate post-procedure recovery area. Typically, vascular sheaths are removed and hemostasis is achieved with manual compression. Although a variety of vascular closure devices are available for use, none have proven superior to manual compression with regard to preventing bleeding complications post-procedure. In this video, sheath removal with manual compression is demonstrated. Prior to sheath removal, the area is cleaned with a sterile cleaning solution. The area immediately above the sheath skin entry site is palpated to feel for the femoral artery. While holding pressure on the femoral artery above the sheath at the approximate area of arterial entry, the sheath is removed. The area is allowed to backbleed for 1 or 2 beats, and then firm and steady manual compression is held. Underneath the skin, the artery is being manually compressed up against the femoral head, which provides a solid surface on which to assist in manual hemostasis. Care must be taken, however, not to hold such firm pressure that the distal pulses are not detectable, as doing so increases the risks of lower extremity vascular complications such as thrombosis. By rule, the duration of manual pressure is 2 minutes per sheath, French size. So for a 5 French sheath, approximately 10 minutes of manual pressure is held before checking for adequate hemostasis. If bleeding is still observed after the allotted time, additional pressure should be held until hemostasis is fully achieved.